Hello, I'm Dr. Kathryn Schmitz, and I'd like to welcome you to this satellite session entitled Lifestyle Assessment in the Real World, Innovation to Implementation to Impact. And our first speaker in today's session is Dr. Daniel Santamina from the University of Toronto. Dr. Santamina is an associate professor in the Faculty of Kinesiology and Physical Education and is cross-appointed in the Faculty of Medicine in the Department of Surgery. He's a clinical investigator at Toronto General Hospital Research Institute within the Department of Anesthesia and Pain Management. He completed his PhD in kinesiology at York University and did a postdoc in the Department of Surgical Oncology at Princess Margaret Cancer Center. His research focuses on the effects of preoperative conditioning known as prehabilitation on physiological, functional, and psychosocial outcomes in surgical patients. Dr. Santamina is also actively involved in implementation research related to surgical prehabilitation and exercise oncology.
Hi, everyone. It's a pleasure to present among an esteemed panel this session, and I want to thank the AICR for having me. My name is Daniel Santamina, and I'm an associate professor at the University of Toronto in the Faculty of Kinesiology and Phys Ed, and a clinician investigator and co-director of the prehabilitation program at the University Health Network. The title of my talk today is Implementing Hospital-Based Surgical Prehabilitation Strategies to Create and Measure Impact. In this presentation, I will briefly review prehab for people with cancer, describe our experiences with clinical integration of a prehab service at our hospital, define our metrics of success and how they relate to quality improvement and research frameworks. And I hope to have a few minutes after the presentation to answer some questions. To start off, it's important to understand the concept of prehab. This figure by Carly and Zavorsky, published in 2005, probably started what we now know as contemporary prehab. To briefly describe this conceptual framework, patients in the black line represent the usual surgical course. Patients generally progress towards the day of the procedure, maintaining their health. And with the procedure, they typically have a marked decrease in functional ability and perhaps below a threshold of independence, denoted by the horizontal hashed line. But over time, and often with rehabilitation, patients recover to baseline, where the concept of prehab is represented by the dotted line, where up to the day of the procedure, patients increase their functional ability through various health behaviors, which creates a buffer to tolerate surgery even better. Consequently, they fall below the functional threshold for a shorter period of time, and hopefully they return to their baseline earlier. Now, while this represents the foundational concept, the last 15 years have brought much more insight into the preoperative experience. And perhaps rather than maintaining a constant functional ability prior to surgery, as is indicated in this green line, patients often decline in well-being under the stress of impending treatment. And moreover, we can probably all appreciate that many patients aren't so well at the time of surgery decision. So they may actually be teetering on the threshold wherein the surgery may cause them to remain function dependent well after the procedure and possibly indefinitely. This definition of cancer prehab by Julie Silver and colleagues has been extremely useful at capturing the overall goals and components of prehab. And it reads, a process on the continuum of care that occurs between the time of cancer diagnosis and the beginning of acute treatment. It includes physical and psychological assessments that establish a baseline functional level, identifies impairments, and provides targeted interventions that improve a person's health to prevent or reduce the incidence and severity of current and future impairments. The definitions and concepts related to prehab continue to evolve. And in this particular framework, we propose that prehab can play a role in surgical as well as non-surgical treatments. And for a given patient, prehab may be indicated at multiple times. For example, as shown here, prior to surgery and subsequently prior to adjuvant therapy. And the nature of prehab in these settings can be very different, which depend on the preceding health factors and other treatments. And the goals of prehab in these settings may also be different. So there really may be two prehab windows for a given patient in a standard course of care. But I think it's ultimately useful to view prehab within the overall continuum of oncologic care, where it follows diagnosis and precedes various treatments. It's also important to consider prehab over the entire cancer journey, including recurrent or secondary cancers, which often require treatment as well. So practically, what are we talking about when we're talking about prehab? Well, Prehab is moved largely towards a multimodal intervention, which often includes medical optimization, exercise, dietary and nutritional support, psychological counseling and/or stress management, and the cessation of tobacco use or the use of other health impairing substances. These are often supported by a health behavior change strategy to ensure high compliance over a very short term of time, but also with the intent to maintain these health behaviors over a long period of time after treatment. Now, the concept of multimodality is, as the math suggests here, 1 + 1 = 3, because these modalities generally have a synergistic effect with each other. For example, exercise may be more successful with dietary supplementation, and conversely, exercise may increase appetite to support greater caloric consumption if that's needed. Ostensibly, the whole is in fact greater than simply the sum of its parts with multimodal prehab. And to maximize the benefit, we need to target those who likely need it most. And personalizing the intervention to ensure compliance and benefit is also important. So frameworks like this one presented by Mina and Carly in 2018 are definitely key to understand. And they include screening for surgical vulnerability, a comprehensive health assessment, and individualized prehab programming. So these are the frameworks. This is what prehab is, as is referred to these days. And from a research standpoint, cancer rehab and survivorship have grown immensely over many decades, and they have an incredible body of literature to support their integration into care. Relatively speaking, the body of scientific literature supporting prehab is quite nascent, but it is catching up. In fact, as of the seminal publication by Carly and Zavorsky in 2005, the rate of publications has started to grow very quickly, with exponential growth in the last decade. Importantly, nearly half of the papers published include a reference or application of prehab to people with cancer. And so what do these data reveal? Well, a simple look at very recent systematic reviews in 2021 show that prehab for a variety of different surgical subgroups is safe and feasible. And importantly, safe and feasible with high intensity exercise protocols, including among patients who are frail or older. In terms of benefit, the literature highlight improved pre and post-operative functional capacity, better quality of life, shorter length of stay, and reduced surgical complications. And surgical complications are worth highlighting given their impact on patient and system outcomes. When we take a closer look at surgical complications in a meta-analysis of prehab studies with this outcome, we find that the odds ratio of prehab events ranges from 0.52 to 0.63, or roughly a 40 to 50% lower likelihood of a surgical complication in prehab patients versus those who receive usual care. Now, while compelling and promising, the data are, however, not without some criticism, and more and better quality RCTs are needed to add confidence and precision to our understanding of the prehab benefit. Nevertheless, conceptually and based on the current evidence, prehab is recommended widely as a best practice strategy, including in this recent perioperative management guideline by numerous authorities in the field. So, given the growing number of recommendations to implement prehab, how do we actually do this? Well, thankfully, following the efficacy and recommendations of prehab implementation, there have been a number of studies showing how we can do this. So these typically comprise business cases or steps towards developing a prehab service. I love this table in a recent paper by Bates, West, and Jack that concisely highlight the important considerations for developing a prehab program. And in the development of our prehab program at the University Health Network, this is an extremely useful set of practical steps towards implementation. And generally, they include things like mapping out the surgical pathway, broad consultation across various stakeholders, assessing feasibility, and integrating quality assurance components to make sure that we can appropriately capture success. So for us, we started with a robust implementation science project that sought to examine the integration of prehab as a clinical service. And this was entirely done within the scope of a research project. Our protocol was published earlier this year, and I'll touch on it just a little bit here for some perspective. We sought to robustly assess feasibility through various measures, including things like referral rates, patient participation, their characteristics. We wanted to understand more about the prehab window, that is, how much time do we have for various patients before surgery. We wanted to look at safety and other programmatic factors like the location preference, whether it's in hospital or at home, as well as other barriers or facilitators to participation. We also sought to explore pre to post changes in various outcomes and compare prehab to patients who were referred to prehab but ultimately did not participate. And so we emulated a real world scenario, and we tried to maintain a very broad inclusion criteria of simply adult surgical patients with planned cancer surgery who had fluency in English to participate in the various components of the study. We also wanted to make sure that we only accepted participants via clinician referral, which is the typical pathway for ancillary care services. As recommended, we mapped out the surgical journey to identify points of entry, which generally included the time of treatment decision, or during follow-up consultation with a surgeon, or possibly within a multidisciplinary cancer conference where neoadjuvant treatments may be defined. Sometimes we might consider patients from pre-admission clinic, although the time frame from a pre-admission visit to surgery was often quite short. But ultimately, the goal was to maximize the time of prehabilitation by minimizing the time of diagnosis to the initiation of prehab. As mentioned, we accepted patients only by referral, as indicated here on the left. So again, similar to other programs at our hospital. And then we included a brochure in all of the surgical clinics so that patients were free to review the literature at their leisure. Our program was multimodal, as described previously, and comprised of medical optimization, exercise, nutrition, psych, and smoking cessation, if appropriate. And important to note, we had to move to a 100% virtual program at the onset of the pandemic. Largely, this was retained after programming started to open up a little bit more because of the preference for this remote delivery style. So obviously, capturing an understanding was key to this particular project, and we wanted to understand feasibility metrics, as well as a lot of patient experience outcomes. So we conducted in-person assessments throughout the course of prehab, as well as at 30 and 90 days after surgery. We wrapped up this particular project's enrollment only a few months ago at the end of August. And as of then, over 20 months, we received 116 referrals, 84 of whom participated in the study. 80% of that 84 actually agreed to participate in prehab, and the 20% that did not want to participate in prehab have served as controls. Now, we don't yet have all of our numbers analyzed yet, but we do have a few metrics of success that I'm happy to share. And I think it's important to share perhaps the perspective of the surgeon. One surgeon said, in reflecting on the patient's entrance to the operating room, the patient had a bit of a difficult time with his chemoradiation and had lost quite a bit of weight. And because of this, we referred him for our prehab program. And in addition, we delayed his surgery by a couple of weeks to give him a little time to recover. This, I believe, was beneficial in terms of both his energy and functional status, and his weight prior to surgery was up 56.6 kilograms from his lowest extent at 50.5. So the surgeon voice here was particularly powerful to us and resonated across a number of patient notes. And this complements a growing body of qualitative literature describing the benefits of prehab in people with cancer, such as work done by my PhD student, Priya Brambhat, who recapped a patient's experience where the patient said, I benefited a lot from prehab because it caught me in a time just after diagnosis when things were pretty scary and pretty awful. And I felt like prehab was just one of those pieces of my plan for positivity during this whole thing because it was setting a tone for recovery. So we have some really great experiences and understandings about the role of prehab as a clinical program within the context of our institution. And with a bit of a push, we thought we could actually bridge the gap between implementation science and program implementation. But we needed an opportunity, and we were very fortunate to be afforded the opportunity to apply for the Backlog Recovery Innovation Challenge by our institution surgical program. So I think what I want to do now is talk a little bit about how we engaged with this process towards the implementation of our service. So here are a few steps that took us to where we are today, which is a clinically integrated prehab program. Step one, we had to have a vision and a mission. We really had to have a pointed direction for where we were going. So our vision is to have the healthiest people who need surgery. And our mission is to make UHN patients as healthy as they can be prior to surgery. The second step really is to align our mission and vision with institutional values. And at least at UHN, there are a number of UHN essentials which we thought absolutely apply to our mission and vision of prehab. But we could really find alignment with core principles such as operational excellence, compassionate care and caring, and quality and safety. And so this was important to make the case that what we were trying to deliver within the context of prehab really did fit within the institutional goals. Step three, we had to highlight the opportunity. We are a high volume surgical center. We do a lot of complex procedures among some of the most difficult or challenging cases. And patients often feel underprepared for surgery. So there really was an opportunity to improve the overall well-being of the patient and the system. And then we proposed what we thought was a solution in the form of prehab, which we thought would empower and educate patients, improve pre, peri, and post-operative outcomes, reduce surgical complications, and overall reduce healthcare costs. Now, it was really important to provide an economic projection. And these are just a few of the different analyses that we did to make our case for the viability of prehab. We looked at things like profit and loss calculations, the number needed to treat to prevent an adverse outcome, as well as break-even points relative to the investment of prehab and the surgical complications that it may prevent. And it was important to highlight that these cost estimates did not factor in a number of other preventable costs that may be attributed to prehab. But in addition to the economic analyses, we did have to absolutely highlight that this is really about the patient, and important outcomes can be achieved with the implementation of prehab. So maybe not a huge new step, but I think a little bit of luck goes a long way. And we were awarded with the grant to allow us to pilot our program, which we are now underway. So that step 4, design the program. And this was easy because we had the backbone of the implementation science project that we could leverage to get going right away. We had to align our program with quality targets and frameworks. And this is step 5. And I think this is crucial because to make the value proposition of prehab, it does have to meet with the other metrics of success of the institution. And metrics of success indeed need measures. So we had to choose what we thought would be our targets for success. In this particular case, we looked at complication rates after surgery. And so this is exactly what we're trying to prevent, and use the IHI triple aim approach at describing how our program improves health outcomes in this setting. We use our standard metrics as described previously related to the success of a program. We have a 45-day post-op assessment, and this is really to transition patients to rehab, not necessarily to continue to deliver prehab. So I think the idea of measuring impact is really key, but also can be looked at a broader perspective that includes how this might advance literature. And one possible consideration is the use of a core outcome set. And for those who are not familiar with core outcome sets, they're an agreed upon standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. And the idea is that this core outcome set essentially advances the literature by ensuring that systematic reviews have homogeneity rather than heterogeneity in outcomes, which is a common limitation of our science. And in fact, a good example is a core outcome set for trials in people with COVID-19, where there are primary, secondary, and tertiary outcomes that are recommended for all studies looking at COVID-19 outcomes. So as we look forward, step 7, at least from where we stand, is about expanding, evolving, and enhancing. And for us, when we think about where we're going next, it's about how do we automate the referral process to reduce the administrative burden? How can we triage to different types of prehabilitation for all patients so that the highest resource prehabilitation can be delivered to only those who need it, and resources could be saved for those who may be in better health? We want to make sure that we can expand our multimodality offerings, so perhaps introduce things like sleep hygiene or wound care education. We want to strengthen our pathways from prehab to rehab to make sure that the rehab professionals who are seeing patients have a really good understanding of the baseline function prior to surgical morbidity. And obviously, quality improvement initiatives and alignment with the values of the institution have to remain at the core of this. But that research as well, in ways that advances the field, will certainly help all of us understand a little bit more about how prehab benefits and its feasibility in a clinical setting. And in order to move forward, we need to seek additional resources. And sometimes that means engaging in non-traditional sources of funding. So for us, we have a 3-year plan that hopes to increase our capacity of patients that are seen by 50% year over year over the next 3 years. And hopefully after 3 years, we'll have a fairly robust body of data to analyze and demonstrate our value to the institution. So those were our 8 steps to clinical implementation. And hopefully at the end of 3 years, we'll be able to demonstrate our impact on the outcomes that we set forward to do. Thank you so much for your time and for listening today. And I look forward to addressing any questions you may have. Thank you.
Our next speaker is Dr. Jennifer Trilk from the University of South Carolina School of Medicine. She's an associate professor at the South Carolina School of Medicine Greenville and director of the Lifestyle Medicine Core Curriculum, which comprehensively trains medical students in nutrition, physical activity, behavior change, and student and patient self-care and resiliency to prevent and treat the nation's top chronic diseases such as obesity, type 2 diabetes, and various forms of cancer. Dr. Trilk co-founded and co-directs the Lifestyle Medicine Education Collaborative, which provides leadership and guidance to medical schools across the globe. In 2019, LMED was awarded a second U.S. Presidential Council on Fitness, Sports, and Nutrition Community Leadership Award. She also founded and directs Exercises Medicine Greenville, a comprehensive 12-week medically based exercise and lifestyle program for adults with chronic health conditions. Dr. Trilk.
Hello, everyone. I want to thank the organizers of the American Institute for Cancer Research for putting on this phenomenal virtual conference that we are all attending. I'm very excited to present to you today regarding Exercises Medicine Greenville and what we've done at our medical school and at our Prisma Health healthcare delivery system and in our community to really promote exercises medicine across Greenville County. So the title of my session is Exercises Medicine Greenville, Design and Implementation of a Clinic to Community Physical Activity Health Promotion Model for Healthcare Providers. And I am one of the founding faculty at the University of South Carolina School of Medicine, Greenville. I'm an associate professor there. I also direct our culinary and lifestyle medicine programs, and I am program director for Exercises Medicine Greenville. I've got no disclosures to report, and I'm really excited to share with you the program that we have developed. I call it a classroom clinic community model because we really cover the spectrum from the medical school, and you can see a picture of our beautiful campus there on the left, through to Greenville, South Carolina, which is our community. We work with Prisma Health, which is our primary care providers. We work with Tourist Culinary and Hospitality Innovation Center because we do have a culinary medicine program that the medical students are able to go through. And then our primary partner is the YMCA of Greenville for the patients referred into our 12-week program, which we'll get into in a moment. Just to kind of give an idea, kind of stepping back, the University of South Carolina School of Medicine Greenville is the #1 medical school in the country that formally integrates over 80 hours of required lifestyle medicine content across all 4 years of the medical school curriculum. And when I say lifestyle medicine content, that is nutrition, that's physical activity, exercise, sleep hygiene, stress reduction and resiliency, social connectivity, and also the reduction of unhealthy substance use. So the students, from the time they get to our classroom, really learn and understand the importance of identifying the root cause of all chronic diseases, because we know that over 90% of chronic diseases in the country are related to healthcare, related to chronic disease and lifestyle. In our structure and function, this is just an example of all of the intercellular mechanisms that we go into regarding exercise and physical activity and health. Some examples that we demonstrate are looking at BMI, which we teach the students is really only a screener. And we look more at obesity and body composition. So we look at skeletal muscle, we look at adipose tissue, and we look at visceral adiposity and how that can relate to chronic disease. We get into the associations of obesity, chronic inflammation, and how obesity and a sedentary behavior can really increase the risk of cardiovascular disease, insulin resistance, type 2 diabetes, and of course, many, many cancers, including breast cancer, colon cancer, and lung cancer. We also get into mind, brain, and behavior. So we get into the brain benefits of a healthy lifestyle and how increasing exercise and promoting physical activity in patients is really helping with reduction of Alzheimer's, dementia, and other forms of brain diseases. Of course, there is zero statistically significant difference between understanding the benefits of physical activity and actually adopting a physically active lifestyle. So we teach our medical students how to use motivational interviewing and shared decision-making to help their patients go from one stage to the next in order to adopt healthier lifestyles. And one of those is physical activity. When the students get into their third years, we work with our primary care providers, such as internal medicine, family medicine, and pediatrics, to really implement in what is taught in the classroom into the clinic and into the rotations for optimal patient health with our medical students. And during that time, they will get a lifestyle medicine content. This is an example of what they get for family medicine. They will get lectures in preventive care. They'll get lectures with core chronic diseases such as hypertension, diabetes, and cardiovascular disease. And then they'll get lectures in nutrition and exercise, to where we will bring back not just the biomechanisms related to exercise and nutrition, but really how to counsel patients and give them a fit prescription or a frequency, intensity, time, and type prescription while they're doing their exercise counseling. And then they'll refer to our Exercises Medicine Greenville program, which we'll get into in a moment. Again, they use that motivational interviewing, and they also are tested using OSCEs to make sure that they're performing their motivational interviewing, making sure that they're giving that counseling with exercise and diet, making sure that they're giving that fit prescription, and making sure that if a patient is eligible, to refer them to Exercises Medicine Greenville. So I wanted to give that kind of backstory of where we started in that classroom to clinic to community model, because what we have done with Exercises Medicine Greenville, and we launched in 2016, is we have created a referral process for any patient who has any one of our chronic diseases to start an exercise program within the YMCA and our medical fitness facility at Prisma Health. So we've got a website if you're interested in taking a look at it, and that is eimgreenville.org. And that website will give you a background of everything that we do with our patients. We have 7 designated physical activity community facilities. Like I said, we've got 6 YMCAs. We've got 1 medical fitness facility, the Life Center, which is with us. And we have over 40 credentialed Exercises Medicine professionals to take the patients from the Prisma Health into the community. And what I always say is, this is not about the bigger guns and the tighter buns. As we're teaching our Exercises Medicine fitness professionals, this is much more about chronic disease treatment, chronic disease reversal, prevention of secondary chronic diseases. So the Exercises Medicine professionals are trained that these are Prisma Health patients. These are not necessarily members of the YMCA or their clients, that these are true patients that they're taking on. We have currently 18 participating practices, and I put in parentheses there that we're adding 6 more in Oconee County, and I'll get into that shortly. We're very excited that we were in Greenville County since 2016, and now in 2021, we are branching into a second county, which is called Oconee County, in the area of Seneca, and we'll be bringing on 6 more primary care clinics that will be referring to Exercises Medicine down at Foothills YMCA. So you can see that under the Department of Family Medicine, we have a number of different clinics. These are both residency training clinics as well as primary attending clinics. We've got the Department of Internal Medicine as well across Prisma in the upstate. And then we even have specialty clinics that we work with. And you can see we work with our diabetes prevention program, because we know that across the board, diabetes prevention, the program is fantastic and patients are educated about exercise. However, they don't have an exercise program in which to refer, so we work with our diabetes prevention program. We also work with our Center for Integrative Oncology and Survivorship, which of course is extremely important for cancer survivorship. And patients who are diagnosed with chronic disease and also diagnosed with cancer, you know, they still are struggling with maybe type 2 diabetes or hypertension. So patients who complete their chemotherapy are then able to come into the Exercises Medicine program. We work with bariatrics, either before bariatric surgery or maybe as an adjunct substitute for bariatric surgery, or even after bariatric surgery, to really develop positive lifestyle behaviors. And again, we work with pediatrics and OBGYN. Our participating fitness facilities cover close to, well, it was about 250 square miles before Seneca was brought on board. So I think that we are anticipating that it's approximately 500 square miles. So the point of having that kind of spread is that patients are not having as much of a barrier to getting physical activity, because they can go to either one of these facilities, whether it's closer to their home or whether it's closer to their work. So we're going to back up and give you an idea of how I implemented exercise as medicine and designed it across our participating partners and with the YMCA. We really started back in 2012 when we opened our doors when we opened our doors at the medical school and started teaching the doctors to be how important physical activity is. But then I noticed that if we do not have an ability to refer patients out into a community to where they live, work, pray, and play, that a lot of that lifestyle behavior change that's discussed in the clinic may be lost in the patient's lifestyle. So I started working with our clinical informatics manager, Mary Jane Rogers, back in 2013 to start saying, wouldn't it be great if we could put the physical activity vital sign or exercise vital sign into EPIC, which is our electronic health records, so that it was enterprise. It is a soft stop. So all doctors do not need to ask it, but it's there if they want to. And they can ask how many minutes a day do you exercise and how many days a week, and we can capture the physical activity guidelines. So Mary Jane Rogers was phenomenally successful in getting this done for me. And you can see a picture of her and her team in the lower left-hand corner there. I asked her if she did this for me, what could I do for her? And she said, get all of my team exercise balls. So I really did. I purchased exercise balls for them when she was successful in getting everything into EPIC. I also then worked with Scott Badley. He is our YMCA Chief Executive Officer across Greenville County. He is phenomenal to work with. He understands that it's not just about membership. He understands that it's important that the YMCA can be an extension of healthcare in the community for that behavior change. So we talked in 2013 and he immediately understood. I also talked with Dr. Sinopoli, who at the time was our Chief Clinical Officer back in 2014, to see if it would be possible, from a liability perspective, or to be able to refer patients outside of Prisma into a community physical activity facility. So we really assured that there would be a high quality, liability mindful program that his patients would be going out into the YMCAs. The 4 goals that we primarily had were to reduce obesity, reduce hemoglobin A1C, reduce hypertension, and change this dyslipidemia or improve dyslipidemia in Greenville County. In 2014 and 15, we trained our first 24 exercises medicine professionals. We had that proposal to Prisma Health for a full-time employee for a referral coordinator that Prisma would be paying for. We also did a 4-week operations flow, so somewhat of a dress rehearsal, using Prisma Health employees to see how that referral operation would go through. And then we trained all of our exercises medicine professionals on REDCap, so that every time they saw one of the Prisma patients, they would type into REDCap, which is an electronic data capture system, and it's cloud-based, everything that patient did at that exercise visit. And then we got co-branded and marketed the Prisma YMCA Exercises Medicine logo, which is in the upper left-hand corner there. In 2015, we continued, and in 2016, we were able to get the Exercise Vital Sign enterprise across all Prisma Health for all adults across the county. We got the approval and the hire of our Exercises Medicine Care Coordinator. We designed the program task force and we established that to really say, what is this 12 weeks going to look like? It's going to be adaptable. It's going to be flexible. We have a number of different sites, and not all sites are the same. Neither are all of our exercises medicine professionals the same. So what are our goals and how can we be flexible and adaptive to reach those goals? We completed the exercises medicine full electronic referral pathway through to the YMCA. So not only do we have the exercise vital sign in there, our entire referral process is electronic. And then we created an advisory board and a research steering committee in 2016. So the advisory board, and you can see that I have that highlighted on the website, consists of our chair of internal medicine, Dr. Trilk, and our chair of family medicine, Dr. McGilvery. And I ask them to be our co-medical directors so that we know what is applicable and what is proper for patient care, which clinics that we go to, any sort of adverse events that would happen with the exercise program, any sort of reason that if we have any contraindications to exercise for a particular patient, that they have to come back and get a physician's clearance again. So they are really, really valuable to us in the advisory board as co-medical directors. Sam Franklin is the chief operating officer of the YMCA, and we work very closely with him on the actual organizational process and operations on all of the referral, who is hired, who are the correct very, very highly selected exercises medicine professionals, the exercise professionals, because it's very important that they understand, again, that these are patients with chronic disease. Robin Sturr is the vice president for Exercise Medicine Global. So of course she is on our advisory board. Kendra Rohrbrow is our manager of our Life Center, so our medical fitness facility. And then we've got Brenda Timms, who is our vice president of the Health Science Center for Prisma. And again, Mary Jane Rogers, our clinical informatics manager. We were asked in 2016 to go speak at the National Press Club with the then Surgeon General Regina Benjamin. Dr. Benjamin spoke, and because we were the first in 43 countries to take exercises medicine from an awareness campaign to an actual life program, we were asked to speak there, and that was quite a highlight. We've also published a number of different articles, including The Power of Physician Prescribed Physical Activity, which really goes through our process and that program flow that I discussed. In 2016-17, we pilot launched EIM Greenville with 4 practices, 2 internal medicine and 2 family medicine. And then through 2016 and 2017 up to 2018, we scaled from those 4 practices up to those 18 participating practices. We also created an exercises medicine policies and procedures manual, a clinical workflow guide so that the providers on the clinical side know how to do the referral, and then an exercises medicine Greenville fitness professional training manual and how those professionals train the patients through the 12-week program for both progression of exercise and also to increase their self-efficacy for their behavior change. These particular toolkits, because of the ACSM being very interested in this, is a partnership with the American College of Sports Medicine, and this toolkit is available through ACSM. So as I mentioned, we've got the 18 participating practices, and the program flow that occurs is that through the healthcare system, that patient is referred into our referral coordinating team. As I mentioned, we had an FTE that was approved in 2016. We've actually now broken that up into 2 people. One is the actual referral coordinator. The other one is a nurse navigator so that the nurse can work with the clinics and the referral coordinator can work with the patient. And that is a flow that goes into the community physical activity centers like the YMCA and the Life Center. Within the healthcare center, and each one of the clinics, we have a clinic room poster that shows and prompts the patients to ask, what exactly is this Exercises Medicine Greenville program? So the patients can ask the provider, and the provider can start talking to the patient to see if they're eligible, interested, and ready for that behavior change. We also, in the clinics as well as the waiting room, have an exercises medicine brochure, again, prompting patients to ask for more information on the Exercises Medicine Greenville program. I wanted to take a little bit of a side note just to demonstrate how we've implemented the electronic referral into our Epic health records. And you can see that within the rooming tab, we have right next to vital signs such as heart rate, blood pressure, we've got exercise vitals. So the patient is asked his or her exercise vitals, how many minutes a day do you exercise and how many days per week? And the electronic conversion will calculate that and let the doctor know if that patient is under or meeting the United States physical activity guidelines. If they are not, or if they have one of the chronic diseases, then a best practice advisory will alert and let the patient and let the doctor know that it is the correct time to start talking about utilizing physical activity as a therapy to improve health. And when that happens, the smart set will open. We have implemented and uploaded all of the ACSM's physical activity prescription for health series. And you can see that here is a list of everything that is in our electronic health records. So the doctors can print this out for the patients and have the patients go home and read through it. And here's an example of being active when you have type 2 diabetes. The clinic will wrap up and view and print the patient education and the instructions. And then if the patient is eligible for referral into the 12-week program, the doctor can click ambulatory referral to exercises medicine. And then it also, from the doctor's perspective, keeps a queue of all of the patients in which that doctor has referred into the program. Here is both our referral coordinator, Tori Sanka, and our nurse care coordinator, Stephanie Escuri. As I mentioned, we've got those two wonderful people. So that electronic referral will come into their offices and into their queue. And then they have 48 hours in which to contact the patient to get them referred over to one of those 7 YMCA or Life Center sites. The way that our program was designed was to be very flexible and adaptive for both the patient as well as the EIM Pro, as well as the site in which the patient goes for the 12-week program. You can see on the left-hand side that we have the program into 2 different modules. One is a cardiometabolic module, to where truly 97% of most of our patients go, because if they have type 2 diabetes, obesity, hypertension, they would go into the cardiometabolic module. For those who have musculoskeletal pain, maybe low back pain, maybe osteoarthritis in the knee, then, we focus more on more of a strength training, balance, core stability of a module. So they can go into either one or the other. However, both modules have all components of aerobic exercise and strength training. Over on the right, you can see that we've got needed building blocks. So they've got build stamina, build strength, build learning, build commitment, build mobility and stability. And those are required building blocks in which the EIMG professionals must work with their patients on. And then there are recommended building blocks, such as building fun, build by example, building independence, building connection, and mindfulness. So we're hoping that the EIMG professionals also work with their patients on that. We've got Move to Learn. So we've got exercise handouts for each one of the times that the patients meet with the exercise medicine professional. And here's just a list of everything that they see as the patient is handed the exercise guide. And here's an example of how one of them looks. So this one on the left is setting goals and using SMART goals. And the one on the right is how do you manage stress? So every time a patient comes into their exercise session, they get one of these handouts. So we're just going to go into data from 2018, which we considered that we were at speed, or that we were fully mature in January of 2018, because as I mentioned, we started with 4 clinics in 2016. That was August 2016. But then we added on clinic by clinic by clinic until we got up to those 18 clinics in January 2018. The data I'm going to demonstrate and show you ends in December 2019, because we were shut down all of 2020, starting in February. And we just opened up in late March, early April of 2021, again, from exercise medicine. So we are referring patients back in now. So this is the most complete data set that I have. If you can see, we had yearly number of cross growth of EIMG, the number of new referring clinics they added per year. So we had 3 more, 4 more, 5, 6, and then with a total of 18 clinics by actually 2018, 2019 that we were having patients referred from. We have completed healthcare provider referrals to the program. So you can see we had 91 patients referred in 2016, and then all the way up to 365 patients who were referred in 2019. But you can see that there's quite a drop in actual patients who converted to coming into the program. So those who actually enrolled in exercise training were about 124 in 2019 out of the 365. So about a third of patients who were offered the program actually came into the program. But what was really nice is we had a really nice graduation rate of individuals. And you can see once we noticed that once they were in the program for about 2 weeks, they stayed in the program. So our successes that we demonstrated were that we're at about a 56% graduation rate of patients who entered the program and completed the program, and we were supposed to be on a 74% graduation rate before we were shut down with COVID. So it really was demonstrative of how well the patients really liked the program. We did see reductions in body weight and blood pressure, and we did see an increase in full pay and revenue. One thing that I mentioned before was that, patients did not have barriers. We really tried to reduce those barriers. And one of them was ability to pay. So the wonderful thing about working with the YMCA is nobody's turned away for their inability to pay. This is just an example of the practices, October 2019 referrals. We keep track of how many referrals come from each practice. If the referral was correct, how many referrals we have that are correct at month's end. Are we missing elements such as consent to treat or release of health information? And if we have any outside referrals or inappropriate referrals that come in. And sometimes new residents who are in training, we've had a couple of referrals of individuals who are in either wheelchairs or on oxygen. So we've had a couple of inappropriate referrals, but not much. All right, so here's an example of graduates from 2016 to 2019. We had modest but significant decreases in body weight, both for all individuals on the left-hand side who were referred into the program, as well as individuals who were referred specifically for hypertension. So it was a very modest but statistically significant decrease in body weight. Average body weight decrease was about 4.4 pounds. Our highest decrease in body weight was 52 pounds. This data demonstrates that individuals with who were referred for hypertension versus all. So you can see on the left-hand side, all patients are referred, and we didn't see a statistically significant drop in blood pressures, either systolic or diastolic, which sometimes you don't necessarily want to. But individuals who were referred specifically for hypertension saw a 5.1% decrease in their systolic and a 3.5% decrease in their diastolic. So we found that quite successful. You can see here with the scholarship and the full pay is through the years, we've had an increase in both non-scholarship revenue. So individuals paying the $249 for the 12-week program, which is still a very, very cost-effective program because patients are getting small group training with a personal trainer 12 weeks out of the year, and that didn't increase. But then there's also amount of scholarship provided. Nobody's turned away for the inability to pay, and the YMCA is wonderful about that. So we've had patients pay $5. We've had patients not pay anything to be able to go through the program. We've had great success stories with our program. Here are two that have that have really, really loved the program. Patricia Manley, she lost 26 pounds and she decreased her A1Cs from 15 to 11. She actually was down to 9 points recently. And Curtis Lattimore was able to stand for the first time in over 2 years. We get great testimonials from our patient graduates. So you can see some of them here. They love the program. They love their exercise as medicine professional. They feel like it increased their self-efficacy for behavior change, and they feel very, very welcome. And as a scientist, I really look at statistics, and we do get a graduation exit survey, and our exit survey looks at all of this. And we average about a 4.7 out of a 1 to 5 in a Likert scale for patient satisfaction. We've had some great buy-in with our hospital system as well as the community. So now that I had promised Dr. Sinopoli, our Chief Medical Officer, that we would have a high quality assurance, liability reduction type program, this is now an enterprise type program where everybody at the healthcare system knows about it. We've gotten great community support. So through the YMCA, we've been able to raise $350,000 for those patients who need the scholarship to be able to come into the program. So it's been a phenomenal program, very excited to be with it. So I thank you for your time, and I know that we're going to have a wonderful panel discussion, and I look forward to your questions.
And our next speaker is Dr. Wendy Demark-Wahnefried from the University of Alabama, Birmingham. She is Professor and Webb Endowed Chair of Nutrition Sciences and is also the Associate Director of Cancer Prevention and Control at O'Neill Comprehensive Cancer Center at U of E. Her research ranges from determining mechanisms of action of nutrition-based therapies to developing and testing home-based interventions that are scalable and which improve diet, physical activity, and functional status among cancer survivors. Currently, her research teams are testing the impact of a vegetable gardening intervention among cancer survivors across Alabama and a web-based diet, weight loss, and exercise intervention entitled Amplify among older survivors of obesity-related cancers across the continental United States.
Hi, I'm Wendy Demark-Wahnefried, and it's my pleasure to present opportunities and challenges in adapting, implementing, and evaluating diet and exercise interventions in the virtual world. I want to thank my collaborator, COVID, for speeding this work along. And I just wanted to say that although COVID did speed us along, our appreciation of the virtual world actually started more than 2 decades ago. We had just come off a study where we were tracking the body composition changes that occurred with women on chemotherapy and had really started to pilot some in-person physical activity and dietary interventions. We had a wonderful center, the Center for Living at Duke, where we piloted this work. And we did, in fact, find evidence that we could reverse the adverse body composition changes from occurring. So we were very buoyed by that success. However, we were really disheartened by the fact that it took over 2 years to recruit 10 women to this study. At that point, we knew we had to bring the mountain to Muhammad rather than Muhammad to the mountain. And that's when we really started to do home-based interventions. Our first foray into this area was a study called Strength. It was done in 90 premenopausal breast cancer patients on chemotherapy. And we found that the home-based intervention was feasible. It led to significant improvements in diet, but we were not able to move women that were inactive, screened for inactivity, toward improved physical activity while they were on chemotherapy. So our next foray was Fresh Start. This was done in 543 breast and prostate cancer patients or survivors that were through with chemotherapy. And with this intervention, we found significant improvements in fruit and vegetable consumption, significant improvements in lowering fat intake, and significant improvements in increasing physical activity. However, we had not really seen whether we were able to make clinical improvements. So our next project was Renew, which was done in 641 older long-term breast, prostate, and colorectal cancer patients. Here we saw significant improvements in behavioral outcomes and then also clinical improvements in body weight as well as physical functioning. And you see here that our kits are pretty much the same. They have exercise equipment, exercise bands, pace tapes, pedometers. They also have an instruction book full of content and portion plates. But perhaps the thing that made them most successful was the way that they were tailored. And they were firmly grounded in behavioral theory, social cognitive theory to be exact. And we provided computer-tailored, personalized messaging on incremental goal setting, self-monitoring, and feedback, as you see there in the chart that's on the left-hand side. We also gave personalized feedback in identifying and overcoming barriers. The example there is, how do you eat more fruits and vegetables when you dine out? And then we also had social support in the form of a buddy that was provided that was of the same race, same age, gender as the person, but then also the same cancer coping style. Our interventions were great, but they were not disseminated in this country. They were disseminated in Australia as well as Korea, and then to some subpopulations of Chinese immigrants. But beyond that, they stayed on the shelf, which was very disheartening. Until we got a project named Amplify. Amplify is our newest kid on the block. It's a program project that is comprised of 3 related randomized controlled trials. The first trial is a 6-month diet and weight loss program followed by 6 months of exercise. Second, 6-month exercise program followed by the 6-month weight loss and diet. And then the other is a 12-month combined intervention. Now, we based this intervention off of our previous studies, but then we also went back into the field with 8 focus groups to find out what people wanted in a web-based intervention. We also did in-depth interviews among 48 stakeholders. And then once we developed our intervention, it underwent 3 rounds of beta testing. Our goal is to enroll 652 cancer survivors with oversampling of older, minority, and rural populations. And the clinical trials number is there. This is our homepage. The eligibility criteria for Amplify is at least 50 years old within the Verizon coverage area, because if individuals don't have their own computer, we do provide them with a tablet. Survivors that had to be diagnosed with obesity-related cancers, so localized regional breast, colorectal, endometrial, prostate, thyroid, either localized kidney or ovarian cancer, or multiple myeloma and non-Hodgkin lymphoma. Because this is a weight loss intervention, people have to be at least have BMIs of 25 to 50, be insufficiently active, not enrolled in a diet and exercise program, and have to be English speaking and writing and have completed the 8th grade. We would love to translate this into Spanish, but our budget precluded that. Our homepage has rotating content on it. We have a testimonial that provides role modeling, support, and hopefully will be engaging. That is kind of like the equivalent of our flat print-based intervention where we paired our buddy cancer survivor. We have a daily tip that offers content and engagement. And then we have our key components, our weekly sessions and our progress reports. Key to social cognitive theory is incremental goal setting, self-monitoring, and reinforcement to provide self-efficacy. And indeed, that is a key component of our intervention with charts and feedback that are provided as individuals log in. We also lead people through 48 weekly sessions that are interactive and that have been designed on articulate storyline with lots of treeing algorithms within them. We also have sets of tools for setbacks, making a weight loss plan, setting a SMART goal, and other things. And then we also provide support via the computer, support via Facebook, and we also have the support of those cancer survivors again. And instead of just having a flat print, now we have the luxury of having videos. And I'm going to take a moment just to show you one now.
When I was diagnosed with cancer 3 years ago, I just accepted it. I figured I lived a good life. Whatever was going to happen was going to happen. After all, what could I do? Then one day in our cancer support group, we had a nutritionist come and give a talk. I was surprised to learn that being overweight makes it harder to treat cancer, and it makes my prognosis worse, and it increases my chances of getting diabetes, heart disease, and stroke. She also talked about how important it was to have others, friends and family members give support so I could get to that healthier weight. It was right then that I realized that I could actually do something about my cancer by changing my diet. I also knew it was going to take a lot of support from my family, especially since my husband loved myself cooking. So that evening, I talked to my husband about what I needed to do to beat cancer. I would need to eat more vegetables and fruits, fewer That means fewer sugary foods and more whole grains. It surprised me when he suggested we make those changes together. Well, 4 months later, we are on our way to a healthier life. We've lost weight and we're even cooking together in the kitchen. At our age, I never would have thought getting healthy would be good for our relationship too.
So the Amplify intervention was really geared so that it could be delivered virtually, but we had planned to assess it via home visits. So we had to think fast during COVID on how we would adapt our evaluation. Surveys were easy. Those are easy to do via the web or even through the mail. Same thing with physical activity. We could send an accelerometer through the mail as well. And we were planning on doing D3 creatine to assess muscle mass, also via remote means, all easy. But with our home visits, we were really going to draw our blood via phlebotomy. Well, we switched that to dried blood spots instead. Easy fix. Blood pressure, heart rate through automated portable blood pressure cuffs. So easy, but how do we capture data that we were collecting in our home visits, such as weight, waist circumference, physical performance, and balance testing? These were challenges. So factors in considering remote assessments: weight. When you self-assess weight or ask people what they weigh, they tend to shave off a few pounds, and that's reported in the literature. But we couldn't really afford, our budget couldn't absorb the cost of ARIA scales, nor did we want to have any sort of confounding in our control group. So what we did is we decided to lead participants through Zoom on their own scale, having the partner basically display the Zoom dial on there. And we had individuals weigh themselves twice. With waist circumference, this same sort of systematic bias toward a lower reading has been documented. But Joe Freudenham actually showed that if you use not tape measures, but uncalibrated tapes, that you get less systemic bias. So what we did with our individuals is we provided them with two 55-inch ribbons that were just regular grosgrain ribbons. One end was taped, and during the Zoom call, we had individuals lift up their shirts, show us their belly, put the taped end on their belly button, and then their partner would wrap it around them. Once the partner was done wrapping it around them, the individual rotated so that we could make sure that the placement was good. And at that point in time where that was assured, we had their partner basically take a felt tip marker and mark the point where it overlapped. And that measure was taken twice, and the ribbons were sent back to our research office. For flexibility, this is pretty easy. We sent individuals tape measures that their partner could assess the distance between fingers and toes on the sit and reach test that's depicted there on the left-hand side, as well as the back scratch, which is depicted on the right-hand side. And our assessors basically helped the partner tape those and then really made sure that the partner was calling out accurate measures. However, the other tests that we do were more of a concern. And the tests that we did do are featured there on the right-hand side. So we did balance testing, side-by-side, semi-tandem, and tandem stance, 30-second chair stand, 2-minute step test, 8-foot walk, and 8-foot up and go. These were concerns, one, because of safety. So for our balance and 2-minute step tests, we firmly advise that people perform these by a wall and have their partner nearby to spot them should they feel like they needed extra support. We provided clear instructions of the space requirements for the test, and this is important for the 8-foot get up and go. So you not only need 8 feet, but you probably need 12 feet, and that's what we instructed people to do. We instructed them to put away their pets and to remove any kind of throw rugs on the floor. We did provide print instructions, and we did develop a videotape so that people would be really comfortable with the test that we did before we got on the Zoom call. Then when our assessors did get on the Zoom call, they led individuals again through the tests that we would do. One conundrum for us was when we were taping some of the time tests on our Zoom call, we were getting values that were out of range. And we thought, what in the world could be going on here? And we didn't realize that when you videotape something on Zoom, there is a differential on on the traveling of sight versus sound. So what we needed to do in order to obviate that systematic bias was to tape the Zoom call and then time the tape. And that gave us an accurate measure. We also increased visualization through soccer cones and other visual cues. For example, when we did the balance test, we asked individuals to basically hold their hand on the wall until they heard the command from the assessor that the test was to start. We used the methods of Cindy Blair, who's one of my former postdocs, who actually did some of this pilot testing with the 30-second chair stand and the 8-foot get up and go before COVID hit. And then training on your assessors and certifying them, making sure they're right. What we did not do, however, is we didn't measure upper body strength. Grip strength was foregone because we really didn't have money in our budget to basically afford the bill for reliable dynamometers and the postage that would be required for those. Same thing for the timed arm curls, because mailing a 5-pound and 8-pound weights would have been prohibitive. So a recent report that was just released a few months ago advocated the use of filled milk jugs. And I wish I would have been creative enough to have thought of that. That was released by Agawa just, again, a few months ago. We had an opportunity to test the validity, reliability, and concordance of our new tests and assess these virtually and also in person. And we're able to do that through the DUET study, which thank you very much, AICR, for funding the Daughters, Dudes, Mothers, and Others Together project, and also had supplemental funding from the ACS. This was a sample that was comprised of cancer survivors and their chosen partners. And our sample characteristics for that study, or this validation study, 78% female, 64% non-Hispanic white, over half were college grads, and employed, 72% had annual incomes over $50,000. So this was a higher socioeconomic group, a limitation there. The mean age was 58 and the mean BMI was 32.4. And of our survivors, 81% had breast cancer. What we did is we did 2 virtual assessments followed by an in-person assessment at one of the dyad members' homes, and these were conducted via Zoom. Because body weight was our primary outcome for the DUET measure, we really made sure that our assessments were done as close together as possible. So within a week, but we really were successful in getting them within a mean of 3.3 days. This does introduce some issues that I'm going to address later. And then for data analysis, we did Pearson's correlations, McNamara testing for concordance, Bland-Altman approaches, and paired t-tests. Our findings showed that virtual testing was safe and feasible, no adverse events, which was really our most important concern. We successfully completed 204 of the 220 potential virtual assessments, so 92.7%. Our failures were really due to poor internet connectivity. And if you were going to be doing this clinically, you would just have to reschedule at that point in time. Balance testing was 100% concordant for side-by-side and semi-tandem stances. For the tandem stance, we also had really good concordance, 86.1 to 87.5% concordance, no significant differences between the tests. Our findings also showed significant correlations. This is a chart I'm very proud of. Get a load of those Pearson R's. The lowest one is 0.47, but most of them are in the range of 0.9 and above. So very, very high correlations between not only the virtual visit 1 and virtual visit 2, but the virtual visits and the in-person visit. And then as far as our differences in Bland-Altman and paired t-tests, we found that for the weight, which was our primary concern, our primary outcome, there were no differences, which was great. There also was no differences in the 8-foot walk between either the virtual 1 and virtual 2 visits, or the virtual visits and the in-person visits. But the p-values that are highlighted there show you where we did see significant differences. And we did see systematic reductions or improvements over time. So people got more flexible, people got faster, and that really does speak to practice effects that you do see in performance testing. And had performance been our primary outcome, we truly would have spaced these evaluations a lot farther out. And that, we believe, really does speak to why we got these systematic differences over time. So to wrap up, there's a need for scalable home-based approaches to intervene and assess high need and medically underserved populations. This is especially important in cancer survivors. The proportion of cancer survivors in the US is 5%. That is nowhere near the 50% that we see for cardiovascular disease. So we have to find ways to reach out so that we can really be available and make our programs available to cancer survivors. We have to overcome barriers of time and travel, particularly for our rural individuals. Distance medicine-based approaches to improve diet and exercise are showing success. We got to keep on going and pushing the needle in this direction. And virtual assessments appear to be safe and feasible, but this is work that really is where more research is needed. There's some great references out there. I do point to the reference of Cindy Blair, but also Carrie Winter-Stone has made some really great advances here, as well as Agawa. And I really hope that we can publish our findings soon too. So with that, I want to thank my Amplify team. I couldn't have done it without them. They are terrific. And just want to point out that if anybody knows of a cancer survivor anywhere in the continental US that fits Amplify criteria, we're ready for them. We'd love to have them aboard. So thank you very much for your attention.
Welcome back. We have quite the audience. I don't know if our speakers have had a chance to look over it, who's listening here, but it's quite the who's who. So welcome everyone to this session. That was really quite a wonderful set of talks. We have a number of questions for each of you. And so I think I'm actually going to go in reverse order if I can. So Wendy, you're up first with a couple of questions. One of them is actually from me, and you may have said it at the beginning and I missed it, but are you evaluating cost?
Yes, we are.
Okay.
So
can you talk about that a little bit?
Yeah, so Maria Pizu is a health economist. She's on our team. And we are looking at health utilities, and we're translating those costs as far as medication use, ER visits, hospitalizations, and then comparing them to the cost of the intervention. So yeah, that's a very important component of, and I think Jennifer kind of hinted at it in her presentation as well. Yes, we are very concerned about the clinical outcomes. However, the people that make decisions in our lives are really probably more concerned about the bottom line. So we have to really help the science in that area and include those outcomes in our research.
Okay, so the next set of questions for you, Wendy, is really asking you to get out a crystal ball a little bit. Do you think that future interventions are going to remain primarily remote? Or do you think we're going to go with more hybrid sorts of things? I'm going to ask a few more things and then let you talk. Have you seen any demand for return to in-person in your work? And do you think that distance-based work makes that initial ascertainment, that initial sort of recruitment and contact harder? I'll let you talk to those.
Okay, that's a tall order. It's really good that I come from a gypsy background and I can pull out my crystal ball. The thing is that I think it really depends on what your research question is. I think there are some research questions that only can be addressed, with in-person interventions. And so there's not going to be a complete replacement. And I also think that there are people who want to do that in-person or have that in-person contact. And that being said, however, I think there are so many people that we are not reaching with our interventions. And I really do think that the virtual experience can really help those people. We can deliver virtual programs that can make a big difference. And the one study that I do want to call out is a study by Melinda Irwin's group. It's always been said for years, in-person interventions are superior. And I always said bunkus to that. I think the person that shows up for in-person programs is decidedly different than the individual who will show up for a virtual or a home-based program. And I think the two of those are intertwined. And so Melinda's group, she did the LEAN trial, where she actually took people and they were randomized to in-person versus virtual versus a home-based intervention that was delivered via telephone counseling and mailed materials. What that study showed, and it was really, I think there's only been 2 studies like this done. And Melinda, I want to call out a special thank you to her. That study showed no differences between the 2 interventions. So this myth that interventions are so much better if they're delivered in person, I think we need to, now granted that was just one study and we have 2 studies which showed these findings, but I think we have to be careful about what we say about interventions. And, again, it's all what they're aimed at, right? It's your outcomes that are important. The other thing that the virtual interventions will help us do, they will help us probably crack the cost barrier. They are cheaper to deliver overall, but again, they're not going to supplant everything. So that's my crystal ball.
Okay, thank you very much. So Jennifer, I'm going to turn my attention to you with some questions. And in light of what we were just talking about, I think I want to shift it to say that there are questions for you that have to do with what if you can't do these in-person YMCA programs? So the question is, YMCA has obviously been a powerful partner in this initiative, but the pandemic has a big impact on people's willingness to engage in in-person group physical activities. So the question is whether the EIMG program is amenable to a more remote deployment.
Yeah, thank you. And great to see you, Katie. And Wendy, what a phenomenal talk. It's always, I love this. I love this. It is such a great question. Currently, it wasn't the focus of Exercises Medicine Greenville. However, would the program be adaptable to a more remote deployment? And I do believe that it would be able to. Look at what we're doing now. Look at it. I myself have been at 3 different conferences in the past 4 days. I've been in Texas, I've been in Denver, and now here, which would have been Virginia. So look at what we could potentially do with our exercises medicine professionals if it was a case that we wanted to move forward and we're not able to reopen. When we did reopen in March of 2021, we did follow all CDC guidelines. And I know after speaking with Robin Sturr, who is in Southern California with us in South Carolina, that YMCAs did not open for months after we actually did open. So would it be an adaptable program? Even though that's not a focus that we did do, we do also pride ourselves on the fact that we want it to be a flexible, adaptable program with main goals. Could we have EIMG professionals working with groups within a virtual setting? We certainly could. I do believe that that would be possible. It is not a direction for us right now because we are fully open.
Okay, so that actually, I think is kind of an answer, but I want to give you the opportunity to reflect further if you want on a related question. Are there any ideas to implement EIM in areas that don't have YMCAs? So rural areas with no gyms or urban areas with transportation challenges. How would you address that if you were to take EIMG and make it something else?
Yeah, these questions we have addressed, actually. We have looked at this I'm in Travelers Rest, South Carolina, which is a very rural area within Greenville. And we have looked at the possibility of being able to do this in rural areas. The number one thing that we have talked about is even though there may not be YMCAs, at least in the South, there are a ton of churches. Church gatherings are areas. Other areas such as community centers are possible. It doesn't necessarily need to be a YMCA. And I'm telling you, the YMCA is the best organization to work with for this particular one, primarily because they understand the extension, being an extension of healthcare, and primarily because the YMCA, national YMCA, is no one's turned away for the inability to pay. So the YMCA national, their mission is to find opportunities and to reduce barriers of entry. Now, having that said, the CEO of our YMCA, Scott Badley, when we get to that point, because by the way, Dr. Katie, we now are not only expanding into one additional county, Oconee County, we are now expanding into Pickens County. Pickens County is very rural. So we will be in 3 counties by 2022. And we are looking at those things. So the YMCA CEO, Scott, has said, even though there are not YMCAs there, I have plenty of exercises medicine YMCA trained and hired professionals that could go into those settings. So you need the people and you need the places, and the places can be anything if we have the people.
Yeah, I think one of the things that I'm sort of fascinated by your partnership with Y is, I work in the Harrisburg area, and there is a YMCA, the Harrisburg YMCA, that does a whole lot more than Harrisburg. They end up becoming a resource for the entire state for certain things. So it sounds like you have one of those Ys. And so you're lucky to have one of those Ys. I think it might be really interesting to study what happens to an EIMG-like model if you find yourself in a place where you don't have that kind of Y, where the resources are not there.
Sure. And I can't speak to that because of how blessed I am to be able to work with the organization that we do have. Again, right before we were shut down with COVID and looking into Travelers Rest, although Travelers Rest does have a YMCA, they also have a high school. And
it also just has a great name.
It does, and I can tell you the rationale behind the name later. But you can look at churches, you can look at high schools, you can because you can look at a number of different places as long as you have the people. And if there is not a YMCA organization around, I would highly recommend those who are interested in a program such as this to reach out to Robin Sturr. who is the Vice President of Exercises Medicine with American College of Sports Medicine, and we will find a way. We can definitely help and help you implement that, help you design that. That's something that we'd be happy to do.
So I have 3 more questions for you before Daniel's on the hot seat from audience members. And one of them is coming back to this issue of cost. And this comes from Melissa Maton-Shepard. Thanks for sharing your story of Exercises Medicine Greenville. It is a great model that will hopefully be replicated elsewhere. Could you share more about how it is funded and how you have made it sustainable in terms of funding?
Sure. So let's start from the Prisma Health side. After having we'll start with the Prisma Health side, go into, because I'm at University of South Carolina, Greenville, which is our medical school that's on the Prisma Health campus. And again, very, very blessed to have a lot of individuals who were champions for this. So on the Prisma Health side, to speak with Angelo Sinopoli, Dr. Sinopoli, and say, would you please give me a 1 FTE? I want 1 FTE in order to be that referral team, that nurse navigator and referral coordinator. Can I have that 1 FTE for referral? And that was approved. That's something that we did back in 2015. But we really are only, Prisma is giving the cost of an actual person. That is one. The in-kind cost has been tremendous because of the belief that we want to be a community provider. So the in-kind cost with our advisory board once a month for the time allocated for Dr. Tilkmeyer and Dr. McGilvery, as well as Dr. Thames, one of our vice presidents, that is all in kind. So that's volunteered cost toward implementation and help of implementation for the program, as well as our clinical informatics manager. Our clinical informatics manager, Mary Jane Rogers, she and her team were approved by our vice president of Prisma, Dr. Brenda Thames, to utilize 1 to 4 hours a month to work with clinical informatics. So anytime that we have to change any programming within our electronic health records, they're able to put in a ticket and get that ticket into the queue and then change the programming for the Epic electronic health records for EIMG. So it's been a lot of in-kind cost, labor of love from the Prisma side. From the YMCA side and the Life Center side, those are already individuals who are employed by the YMCA. So they are fitness professionals employed by the YMCA. The difference that when we moved into EIMG, that Scott Badley did in June of 14, he actually had everyone reapply for their jobs, and anyone and everyone who wanted to work as an Exercises Medicine Greenville professional had to have a bachelor's degree in exercise science. So they compensated those individuals with bachelors to work with the exercise science. They're already paid for by the YMCA because they're not 100% EIMG providers. They may have one EIMG pro may have 2 classes a week, a Tuesday, Thursday, or a Monday, Wednesday. That is an hour each time. So that's 4 hours out of a week. But that professional also is working as a wellness coach for the YMCA and also personal training for the YMCA. So it's a shared resource, and again, from the patient perspective, the cost of the program is $249 for someone like us who would want to go into the program, who can afford to pay. And I will say $249 is a pretty cost-effective program to have a 12-week training program twice a week with a personal trainer in a small group setting that's no more than 6 patients per one pro. That's money that goes back, that $249 goes back into the pocket of the Y to help supplement those who cannot afford it. And then the Y, through their annual giving fund that they do every year, all Ys do their annual giving every year. They have earmarked the percentage of their annual giving that would come into Exercises Medicine Greenville. We've also had a wonderful program called 40 Men for Change. 40 Men for Change were these 40 Christian men who decided to rally around one of their men who was 42 years old and had a brain tumor, had a glioblastoma. And what he wanted to do was to run a marathon, and these 40 men ran with him on the marathon, and they raised over $250,000. $75,000 of that came to EIM Greenville. So it's really, it's a combination of how is that afforded? It's in-kind contributions and understanding, as Dr. Tilkmeyer says, it is the right thing to do. So he, as a chair of a department, volunteers his time. He allows for the clinical informatics to volunteer their time 1 to 4 hours a month. And then also from the YMCA side, those are already individuals who are hired.
Thank you. Okay. So this question is about kickback, and it actually arises out of something that Dr. Demark-Wahnefried presented in a separate session about how people who are overweight or obese in Alabama did not necessarily think they were overweight or obese. And some might even think they're underweight. So the question to you, Dr. Trilk, is, have you had any pushback? Has anybody been eligible for the program because they were overweight or obese, and you told them that, and they said, no, I'm not, or, been insulted in some way? So has that happened in EIMG?
This is such a great question, because as a medical educator, and I teach in all 4 years of the curriculum of the medical school, in the second year, we have what's considered an obesity panel, but we've got a healthy body image panel that comes in with individuals of all different weights. And our medical students are very well trained and versed with patient-centered, looking at a patient-centered and looking at shared decision-making with individuals who are patient-centered, who may or may not feel as though that their particular image or their particular body or their body composition is healthy versus not healthy. We take a look at this from a health standpoint, not necessarily from a body weight standpoint. The short answer is I have not ever heard of any kickback from any providers who were yelled at because they were referring a patient to the Exercises Medicine Greenville program. If you remember, our first prompt is the exercise vital sign. So our first prompt is how many minutes a day, how many days a week. So if that individual's under the United States physical activity guidelines, they're at risk of health problems. They also may or may not have extra body weight. They may or may not have type 2 diabetes, hypertension, dyslipidemia. So it is the comorbidities in which make them eligible for the program. The other thing that I teach my students, and I know that our doctors talk with patients, a 12-week program is not necessarily you're not going to necessarily see a huge reduction in weight for individuals who are looking to go through a 12-week program to lose body weight, scale weight. They may see a change in body composition by improving their fat-free mass or skeletal muscle and maybe reducing some adiposity, but they may not see a change in scale weight. So that I know that that's kind of a little bit long-winded answer of, we have not ever heard of any kickback from a doctor prescribing EIMG. And we also do counsel the patients, especially through the 12-week program, because it's all about behavior change and healthy lifestyle, that we're looking at their health, not just their weight. So we are looking at the health of the individual and improving those other comorbidities. The other thing I wanted to mention too, I noticed in my slides, I checked yesterday, we've had 250 graduates from our program. We were shut down for 1.25 years, but we've had over 250 now graduate from the program.
That's great. So that actually leads me to my last question for you, and that is, have you done any long-term follow-up on those finishers?
We have a grant in to be able to look at the long-term follow-up. We have an implementation grant, interestingly, into NIH, and then also we have a smaller grant into the Duke Endowment Fund here in the South Carolina to look at both look at implementation on the healthcare side. So if you noted in my talk, We had approximately in 2018, 2019, we had a 33% conversion rate. So I want to find out, are the doctors handing out these referrals like Tic Tacs? Or are they actually taking the time to see if this patient is eligible and ready for this behavior change? Because I was just looking at the data, I'd mentioned 2018. In 2018, we had a 62% graduation rate. In 2019, we had a 65% graduation rate, but we also lost patients because of COVID who were supposed to graduate in January, February. We lost that, so that went down. But so our conversion rate, we want to work on to see if we can up that and work with our doctors. And Katie, you know, this is an important topic for us as well, is how do we get doctors to adequately refer patients into a program? But we know that the program itself, if that patient comes in and is with us for at least 2 weeks, the behavior change is starting to occur. And our goal is to graduate them with the highest enough self-efficacy that they can continue on their own.
Thank you. Thank you so much. So Dr. Santamina, I get the chair's prerogative and ask the first question of you. And that is, I want you to comment. I talked to somebody about your talk, having listened to it when you reported it. I talked to it and somebody said to me, yeah, but he's in Canada. So I just want to say that, you know, the topic has come up and I'm sure you've heard it before. And so the question is, how do you think that your work would shift if you were attempting to do what you do with rehabilitation in a US-based health system? Or flip it, how much do you think what you do is facilitated by a single payer system? Can you speak to that a little bit?
Sure. And I think the first thing I'll state is that the rehabilitation literature is international. So it's not just Canadians who are working on it, but rather it's an international group or number of groups that have found similar findings to what we found and have started their own programs as well. And in terms of what we may find in an American context, I think I would point your colleagues specifically to the work by Dr. Englesby and colleagues out of Michigan. And this is the MSHOP program that specifically, and MSHOP stands for the Michigan Surgical Home and Optimization Program. And they did a cost effectiveness analysis based on their $100 per patient home-based prehab program prior to surgery. And they found significant cost reduction associated with participation in that program in the several $1,000s per patient. So in terms of an economic benefit associated with prehab in an American context, and I think that there is homegrown evidence in the US for its benefit. I think it's also worth noting that we worked on a cost effectiveness or a cost analysis or a financial projection associated with prehabilitation that utilized the odds ratios from recent meta-analyses, as well as the best estimates of cost of complications, from which the best data we could find was from the Veterans Affairs evidence in the US. When we paired a range of odds ratios from those meta-analyses with the complication costs and the prevalence of complications in a cancer setting or in a surgical setting, there was still a significant cost savings even at the lower end of the odds ratio range in terms of the cost, in terms of the complication rate reduction from prehab. So that publication we hope to come out in the next couple of days in current anesthesiology reports. But really, we've tried to provide the best evidence using American dollars. So I do think this does cross the board, so to speak.
I sure hope so. I sure hope so. So question from an audience member, is there any research comparing the sustainability or endurance of behaviors introduced at the prehab state as opposed to the rehab state?
Yeah, I mean, I'm not sure if there's evidence directly comparing the amount of adherence to a prehab intervention, which comparatively speaking is quite acute, several weeks versus sometimes several months in the rehabilitation or more chronic health behavior change literature and exercise oncology. But maybe when we connect the two via some papers, specifically out of Franco Carli's group, they found that those who participate in prehabilitation have better adherence to their rehabilitative interventions or programming. And certainly when we have a short course prehab window for patients in our program, we may not necessarily be able to make sizable gains in physical fitness, for example, prior to surgery, because we may only have a couple of weeks. But in those couple of weeks, we focus on education about their rehabilitation program that they can expect following surgery. So for example, if it's a breast cancer patient, we would focus a lot on the exercises that they may be doing for their shoulder, their back, or their core. And while they may not necessarily change the fitness preoperatively, hopefully what we've done is we've introduced those exercises in the time where patients are more receptive to them and can maybe understand them a bit better.
You mentioned in your talk that you had interest in working to better connect prehab and rehab. Can you talk about, have you attempted to do that? How's it going?
Yeah, I think the vision, I think for all of us, is that once a patient has an indication for surgery, that we really do have an opportunity to follow them from a physical fitness and wellness standpoint all the way across their continuum of care. But not all prehabilitation and rehabilitation programs are connected if there is indeed both of those programs available to a patient. For us, what we're doing right now, and this is in consultation with our rehabilitation colleagues, in particular, Dr. Eugene Chang and Dr. David Langelier, who are physiatrists in the rehab program. And our conversations have lately been about what measures would be most useful for them to understand a person's baseline physical function. So for example, in the head and neck cancer patient population, understanding their swallowing function, their speech function, their head and neck mobility is a great asset for them to mark targets for their rehabilitation program. And as I mentioned before, it's important for us to communicate from group to group. But specifically what we do in our prehab program is we have a follow-up of 45 days post-op to allow us to transition a patient to rehab if we identify them as being a bit slow to recover relative to the expectations. So while we don't necessarily provide rehab specifically, not always is a physician who's seeing a patient post-operatively looking at their functional well-being from the perspective of deciding whether or not rehab is indicated at that time. So we take on that role to try to make that transition for them.
Got it. So the next set of questions. Go ahead, please.
So, the one thing is that we oftentimes have the assumption that, people are just too overwhelmed during the time of diagnosis. And I agree with that. It's very difficult to schedule people. And Daniel, my hat's off to you. It is hard to schedule people during that time. But there, the counterpart of that is that there's some evidence from the behavioral literature, Matt Kruder, who's at in St. Louis, that suggests that when we put people in a very emotionally charged environment, and then we task them, that they actually may be learning that's necessary may actually stick better than the getting them in kind of like a blasé state. So something that we may want to consider, just because I think it's very interesting and can be drawn into this. So with that, I'm gonna mute myself.
No, those are very helpful. Yeah, and insightful comments. It is absolutely a very emotional and stressful time for patients following a diagnosis and a knowledge that they do require surgery. And like you said, at that point in time, I think many of them are looking to be empowered in some way, shape, or form. How do I take care of what I can take care of right now? I got 4 to 6 weeks before I go to the operating room. And I think for the most part, people feel very passive unless they're offered something to do for themselves. And I think rehabilitation actually is a change in philosophy about when treatment actually starts. It doesn't start when you enter the hospital for your surgical date. It starts when you know you need surgery. And the treatment that precedes surgery is exercise, nutrition, psychology, smoking cessation, and other medical optimization strategies. It is a part of the treatment process. It's not something that, at least we think, is a nice to have, but rather is the first step. And because it's often relatively a short period of time between diagnosis and surgery, the drive and the motivation and the adherence can sometimes be heightened in that acute phase.
I wish very much that we had figured some of this out when my wife had head and neck cancer, and we had a month before her surgery, and we did nothing besides panic. for a month, and, afterwards it's like, oh my God, could have been really helpful to her. But so I actually think that, that really makes me think about the implementation side of things, Daniel. It makes me think about, how important it is that, if those doctors who were going to cut off her nose would have told us to stand on our head and spit nickels, we would have, we would have done anything they told us to do, but they didn't tell us to do anything. They said, go home, we'll see you in a month. So I think that in the process of implementation, in the same way that pre-IMG, I think there needs to be a physician that says, I think this is a good idea for you to do this. I think that in prehab, there needs to be a physician that says, I think this is a good idea for you to do this. So, and I look forward to seeing your next steps in that venue. So the next set of questions comes from Anna Campbell. Hi, Anna. The first part is, what are the top 3 cancer types where prehab has really been proven to be effective with, a diverse set of outcomes?
Thanks. And I apologize that I have a very junior attendee in the background who has some comments as well. But in terms of the evidence within prehabilitation in cancer, by far, most of the evidence is in colorectal cancer surgeries. And I think that's where probably most of the recommendations for its integration to standard of care are strong, although they can be stronger with the development of better quality evidence. I think following colorectal cancer, the next group that probably has a strong body of literature is in the esophagastric cancers, and then probably followed by lung cancer. And I think, the common trend here is that these are abdominal or thoracic surgeries that seem to show the most benefit of prehabilitation and the most uptake from the research and clinical community. And this is a bit of a departure from what we might see in the broader exercise oncology literature, where urology and breast cancer typically are the ones that have the greatest attention in terms of these types of interventions or these supportive care interventions. And we certainly do have breast cancer and prostate cancer patients participating in our program. But for the most part, again, this is a very large generalization, but for the most part, these surgeries are relatively low risk compared to some of the others. Again, high generalization, but the recovery time and its association with localized dysfunction, while it is very problematic, their mortality rates and surgical complication rates, which are generally the impetus for a lot of this prehabilitation literature, aren't quite as high in those specifics.
Aren't they also more well coming into the surgery?
They very often they are. Certainly the breast cancer patients typically are younger, very many are fit, and while the men with prostate cancer typically come to clinic or go to the operating room who are a little bit older, again, very often otherwise well, asymptomatic in many cases. And so perhaps the drive to do something isn't quite there. But I will say that I think that the literature in that space is growing for good reason, because there are localized impairments that warrant prevention, mitigation, preparation for. It's just that the drivers of some of this research have been surgical complications, length of stay, and overall morbidity in the operative or acute operative space that don't tend to be as much of a problem in some of the other cancer groups.
Are there any cancer sites for which there is sort of definite evidence that it's not helpful?
I can't think of a specific cancer group where they haven't found some benefit. I think the most recent literature review within the context of prehabilitation in general has found very limited effect, if any effect at all, for total knee arthroplasty or total hip arthroplasty surgeries. So these are not in the cancer realm, but these are localized joint surgeries for which prehab, although studied widely, hasn't necessarily shown to provide much benefit. So I'm not sure, we're working on a study right now in sarcoma, and, it's not a joint replacement surgery. And obviously there are different treatments that accompany sarcoma surgery. We expect that there will be a benefit, but this is work that is really not that, hasn't been done very much to date.
So Anna's last question was about who should deliver the intervention. And I just want to state that I know that there are a number of different interventions. And so I'm going to ask it as a two-parter, who should be on the team, but I'm going to ask very specifically, who should be delivering the exercise intervention?
In the literature, it's typically delivered by a physiotherapist or an exercise physiologist or comparable. And in Ontario, Canada, the kinesiologist is another title that's often used. Those are the three intervention deliverers who are most commonly present in the literature. But I know of fantastic programs that use other health professionals as well, like occupational therapists, in some scenarios, nurses. So I think it's about the qualification and the type of exercises that people are providing. So for example, for some pelvic floor muscle exercises prior to surgery, very often it's done by a nurse or a physio. And in other groups, it may be done by a different health professional. So I think it does come down to the individual's qualifications and expertise in a particular area. But PTs and exercise phys are probably the ones who are most commonly represented. And outside of the exercise group, then, registered dietitians or nutritionists, again, depending on your area of practice, psychologists, physicians, social workers, volunteers play a big role in a lot of program delivery and support. And so I think, again, it really does come down to the specific area, but I would say from a stress management perspective, social work and psych, and then in dietetics, nutritionists and dietitians.
Okay, the final question goes to Angela Fong. Hi, Angela. Can you speak to the provider experiences in your research and any strategies that you use to engage providers or get their buy-in?
Thanks so much, Angela. From a provider's perspective, what we're finding from our team who's delivering the program is that it's highly rewarding for them. And I think that from our perspective, I think that they know they've got a limited amount of time to intervene with a patient. And so we go fairly aggressive. And when I say aggressive, I'm probably not using the right term here, but we're trying to maximize the tolerable dose of exercise, because many of these people are asymptomatic. And this allows some of the exercise professionals to really do things that sometimes they can't do with people who are burdened by the adverse effects of various treatments. From a nutrition standpoint, we provide supplementation and dietetic review or of overall healthy eating patterns. I think this is also very rewarding because, again, you're really trying to optimize the patient and you're not necessarily constrained from, the other treatments that may exist. And maybe to extend some of these, these thoughts to how the surgeons and other allied health professionals who see the patient in the operative, perioperative, and postoperative space. As I mentioned in the talk, there's a good feedback from the surgeons and their teams in terms of what they thought was meaningful for the patient. I remember a nice anecdote on a recent call that basically thought that the patient, probably couldn't go to surgery, but then when they went to surgery, if they went to surgery, they thought they may be too frail to survive it. But we took that person who was on the border of being eligible for surgery, made them robust, went through surgery, and was discharged home comfortably. So I think that at least from our team members' perspective, they're finding value on a case-by-case basis.
So I think that there's kind of a corollary to your prehab work in the neoadjuvant setting. So I think there's increasing interest in pancreatic cancer, for example, in the idea of if there are a lot of patients who are inoperable and they take them through a round or two of chemotherapy towards the goal of seeing if they can make them operable, and that is an obvious opportunity. And I guess we call that prehabilitation, but it's also just exercise during chemotherapy. So have you done any of that work?
We're doing some of that work right now in a neoadjuvant setting prior to breast cancer surgery. And I think this is a really important area because we know the deconditioning that occurs associated with chemotherapy or radiation, and that deconditioning is associated with increased surgical risk. So I think the way we can look at prehabilitation is its preparation for an imminent health treatment or imminent health stressor. And if they're going through something that adversely impacts their health, I think that it's both perhaps a rehabilitative strategy and a prehabilitative strategy at the same time. So probably a little bit of perspective is needed when referring to the intervention during a given treatment phase.
Right. So I'm sort of marveling at, we have three really different types of interventions, one that's very based in the clinic, one that's very based in virtual world, and one that's based in the community. And I kind of want to get the three of you to kind of, do a lazy Susan, sort of round, if you will, of, what would happen if we tried to do, could we do a virtual rehabilitation? Would the exercises medicine, approach work for Wendy's population? I'm curious to see if you all have any sort of thoughts about that idea.
I can jump in first as I've been.
Go ahead.
Yes, I would say that yes, prehabilitation can be delivered virtually or in a hybrid manner. I think that exercise is Medicine Greenville and the virtual programs that Dr. Demark-Wahnefried have stated would be a perfect fit for prehab. We just happen to be doing it in our program in the hospital and trying to build out in ways that connect to the community as well as delivering it virtually. So yes, I think we can do it in all facets.
Wow. Okay.
And I agree with you, totally, Daniel. So but so much has to be done for virtual to improve the engagement of virtual programs. We know that people usually attend to these. The data that we get like from Fitbit or that sort of thing show that people, they follow it for 2 weeks. And then they just kind of gravitate off. And part of that might be because we don't, those are commercial enterprises for which behavioral theory has really not been integrated into those programs, right? They really have been more commercially driven than, I want to say
research-based.
Driven. But in any event, I just think that we need so much more research to get up and moving and to look at the best ways to optimize the virtual experience. Because right now, I think we're pretty primitive as I think we've gone a long way. Don't get me wrong, but we have so much farther to go. And a lot of research has to be done in this area to really optimize the work.
I'm just going to highlight the work of Dr. David Conroy, who is my colleague here at Penn State, president of SBM, who has recently gotten some lovely press for work that he's done to try to address exactly what you just raised, Wendy. He has done some really lovely work to show that if we use some targeted text messaging with those, Fitbits and gadgets and watches and whatnot, and approach it with behavioral theory in mind, that we do a better job of engaging people and getting them not just to increase their steps, but to sustain it. So I think you're right.
That priming effect, how can we best people to use the commercial devices that are available? Because I think those commercial devices can be used, but they need to be optimized and they need to be targeted. If we're going to use them in cancer survivors, well, then we need programs that really can, really can make the most out of that. So we kind of need each other. We need their technology. It's kind of silly for us to reinvent the wheel for some of these things. Yet they need us in order to, again, to really make their interventions the best they can be.
And I'm going to bounce off of Wendy and Katie and maybe even bring in a little bit of the black sheep, that as incredibly important as it is for us to be able to do virtual interventions, that we shall not and should not lose the opportunity for social connectivity. And we all have had small group program interventions to where the bonding that occurs between patients and across the small group is so incredibly significant. So I remember our pilot that we did, we had oh goodness. Well, it was Curtis. You saw the picture of Curtis, and he was in his early 40s, late 30s. He bonded extremely well with a 70-year-old white, raped, small, grandmotherly woman And the two of them were checking on each other to make sure that they made it through the program. If somebody missed or somebody, there was a bonding there that we did not anticipate. So that's something that my biggest fear when you think about social connectivity and moving to the virtual realm, that's something we need to make sure that we don't lose.
Yeah. But yeah, we don't lose, because I think there are ways to bond virtually.
Right. And going to the point of, if we were to move Exercises Medicine Greenville to virtual, I absolutely would significantly bolster up a Facebook group, some sort of group to where we're meeting weekly, or that there's the discussion board or something to where everybody has their phone numbers, and that we don't just lose that aspect of the social connectivity and the social support that happens with an in-person setting.
Yeah. I agree with Jennifer. I think it's really important for physical activity interventions, exercise classes, that sort of thing. And also diet. I do think that we also have to make strides in how we comprise groups, because I don't know about you, I've taught a lot of groups in my time, and there are groups that are magical. And you're kind of pointing out the groups that are magical. There are groups that are nightmares, absolute nightmares. It's just like, oh my God, I can't believe I'm done with that group for this week. And I'm sure everybody that's a practitioner has had that experience. And so, how do we optimize the group? How do we, the composition of that group? Because again, there are some that are wonderful. There are some that are awful.
All right, on that note, you all are rock stars. That was absolutely so much fun. And I can't wait to see what your next steps are going to be. And I will be imitating you all the way. And expect lots of questions from the audience in your spare time. So thank you all. Thank you to the audience for participating today. And thank you to the American Institute for Cancer Research for bringing us all together. Thank you.
Thank you.
Thank you.
I think that the speakers are staying for a moment for a call, for a photo.